26. I am here today. Zafin is busy, but I did bring in a potential co-host, our newest son, Ruben. If there's total silence on the call, then maybe we'll have to call on him to discuss or throw out some teaching points. So he's keeping me company, but he's a pretty chill baby. So hopefully this will go pretty smoothly. Drew, I didn't explicitly ask him. I guess when your parents are clinical problem solvers, you're maybe not asked, you're suggested that you join the discussion. So great to see everyone today. So as I mentioned, Zavin isn't here, so I'm here on my own. I actually am seeing who's here with their camera on. Anne-Marie, I know you've buddied up with Zavin before in two discussants. I don't know if you're interested and available to do so today. No pressure, but send me a message if so. And then we'll also look for two other case discussants as well as someone to present a case. In the meantime, oh, great. So it'll be Anne-Marie and then two discussants. Fantastic. I got a chance to listen to the case presented on Monday with Robbie and Rebecca, and two discussants, Tay the PA and AP, who I see is on the call here. Heard a really interesting case of a 24-year-old man with limited access to care, really coming in with 1 day of acute chest pain, a sort of syncopal episode, and was ultimately found to have extremely high lipid levels in the setting of physical exam findings of dyslipidemia, and found to have 3-vessel coronary disease at 24 years of age. It was a beautiful discussion overall, and just a couple points that I was reflecting on are three things. One is how critical the physical exam finding of some lipid deposits on this man's skin were. He had some xanthomas, sounded like he had the xanthelasmas inside his eyelids. I've only seen those in textbook, I'll be honest, but I actually did some Google imaging after listening to the case and really saw how incredibly subtle those findings can be. Many of them, I'll say, actually they very much looked like what I've considered to be tophaceous kind of gout deposits before. So it really made me recognize, as always, how important a hypothesis-driven exam is. Maybe the team taking care of him got lucky, but maybe someone thought about, oh my gosh, why did a 24-year-old have 3-vessel coronary artery disease, and thought of a familial hypercholesterolemia and then did a dedicated skin exam. But as always, just sort of looking at some of the images online of what look like xanthomas but aren't, and what are xanthomas and look like something else. It's just a great reminder of really making sure the skin is an important part of our exam when we do it, including areas we don't look at. Who looks at somebody's tendon of their heel frequently? That's not part of my routine exam, but for this gentleman, it was really critical to have that finding to figure out why he had an MI. As always, Robbie just gave us a beautiful framework for thinking of really acute coronary syndrome, as the name suggests, is just a syndrome, right? It means for some reason there's a supply mismatch in one of the coronary arteries, and he made the point statistically in the older patient population we see that it is often atherosclerotic plaque rupture and then clot formation on top. But the syndrome can be caused by so many other things. And he went through this really wonderful list that could be relevant to a young man, as was in this case, including coronary vasospasm, anomalous coronary arteries, coronary artery dissection, coronary embolism from a more proximal thrombotic embolic process. So really, it was a great reminder that although most ACS we see is from plaque rupture, it is just a syndrome of acute chest pain, supply mismatch, EKG findings, and figuring out why it happened is critical, hence why catheterization is such an important diagnostic as well as therapeutic move. Third and final reflection is there was some discussion about this patient who had a really huge myocardial infarction, had terrible 3-vessel coronary disease, had a normal echo without any wall motion abnormalities. And the discussion came up of how symmetry can sometimes trick us in our diagnostics, and specifically the balance of ischemia really affecting all part of this young man's heart made no one wall move worse than the other. They all moved a little bit less well. And for that reason, this concept of balanced ischemia, where the ischemia is bad in all territories of the heart, can sometimes sort of give us, in essence, false negatives tests of there is no wall motion abnormality on an echo. There is no perfusion defect on a pharmacological stress test. That's because in a test where we look for one thing being abnormal relative to the rest, if everything's abnormal, that difference may not stand out. So I thought that was a really nice discussion about how a diagnostic pitfall can happen with that kind of testing, where balance of abnormality can actually make the abnormality not be there. Awesome case. It was awesome having Rebecca join in the discussion, and looking forward to another one today. I have not been following the chat while I've been chatting. So what do we got going on? We got some case discussants to join us, Anne-Marie?
Yes, we're still trying to nail down a case, but Boris said he might have a case, so I just need confirmation. And then I think a few different people, Secreti said she could maybe discuss, Drew did, and then did I think AP as well. Let me know if I missed anyone.
Amazing. Multiple peoples. Yeah, Boris, if you got the case, that's awesome. A Boris case is always a doozy, but always great learning. Super excited if that pans out. And yeah, whoever else, sounds like a great group that's interested. Ruben is off the hook in that case. I'll let him know. You're off the hook, buddy. Oh, he fell asleep anyway. Yeah, Boris,
Yes,
awesome.
Boris, would you like to introduce yourself?
Hi, everybody. My name is Boris. I'm from Serbia. I'm fourth year infectious disease resident, currently preparing for my board exam, which is in 1 month. So very nervous about that. And I like to be on CP solvers. I didn't have a time to do it in the last few months, but now I'm back.
Great to see you, Boris. Thanks for joining us. Hope the studying's going pretty well.
We've missed you, of course, so welcome back.
Thank you.
And then I guess who are going to be the discussants today? Sorry, the chat was going so fast. I might have missed who was going to be. Secreti, do you want to join today?
I'd be happy to join, but I think Appy sort of messaged before me, so in case she wants to do it, I'd be happy to do it another time. But whatever they all decide.
Secreti and Appy, maybe?
Sure, I can do it.
Awesome. And those who've listened recently probably know both of you a little bit, but if you don't mind unmuting and telling us a little about yourselves, and then we will turn over the screen to Travis and start hearing Boris's case.
So I'll go first. Hi, everyone. I'm Sukriti. I'm calling from India and super excited for today's case.
So hi, my name is Appy. I'm originally from Thailand, but currently I'm an intern at Mount Auburn Hospital.
Awesome. So maybe for flow, if Sukriti and you and I can team up and tackle the first aliquot and then alternate with Anne-Marie and AP, does that sound okay? All right, Boris, we're ready for you.
You're muted, Boris. Sorry.
A suspenseful beginning to the case.
I was trying to read his lips, but I wasn't doing well at it.
So I said that this case I didn't prepare like previous ones, but I have it in my notes, so probably I must check sometimes if everything is okay. Okay, a 91-year-old male with a history of hypertension and benign prostate hypertrophy presented to my office because of the extreme fatigue, chest pain, dyspnea, and fever. Should we start from there?
Sure, sounds good.
Okay.
Sukriti, take it away.
Thank you, Boris. So super interesting that this is a 91-year-old male. So probably would have to account for what is what would be most common in the general population may not apply because of his age, but I would frame this as an inflammatory syndrome because of the fever. So I probably deploy my IMAID mnemonic right now. As Rabi says, often fatigue isn't a super helpful symptom in terms of localizing in terms of its localizing power, but it helps to understand the severity of the syndrome. And then with the chest pain and the dyspnea, I would first deploy my dyspnea pyramid. So thinking about pulmonary and cardiac causes before I think of others like anemia, a chest wall pathology, or something psychiatric like anxiety. And if I were to layer on the dyspnea pyramid onto chest pain, that would probably I would probably use that to localize more to the cardiac and the lung, and then probably frame it as an inflammatory syndrome with localizing to the heart and the lung. And then for etiology, I would think of what are the infections in this age group, what are the malignancies and the autoimmune processes. Malignancies and autoimmune processes I would consider later because in terms of its treatment, it's important to rule out infections before you start prescribing an immunosuppressant for a malignancy and autoimmune. Also in this age group, I wouldn't think of too many autoimmune or malignant processes. He would be more prone to infections because of the immune system being less working less optimally at this age group, but still keeping all my options open and being super broad with my differential.
Beautiful, Sukriti. I love how you've already sort of framed this as an inflammatory syndrome that's probably affecting the cardiopulmonary system. Really just nice approach to otherwise have what could be a broad list of things already in our mind for this gentleman. Unlike Monday's case, which was an extreme of age at the young end of the spectrum for general internal medicine, now we have an extreme age at the older end of the spectrum. I'll be honest, my first reaction hearing the opening statement was, all this guy has is high blood pressure and enlarged prostate at 91. That is incredible. And hearing Boris say he walked into my office, we know that even as this pretty serious sounding syndrome, because of the inflammatory and the chest symptoms that you highlighted, Sukriti, something very serious is going on, but in a host who's at a really functional starting point for his age. Yet, Sukriti, I completely agree with your point. His extreme of age, even if he has a minimal past medical history for now, does put him at risk for all of the conditions that we just are more prone to as time goes on, both of because the aging process itself, environmental exposures, things that life has exposed us to, et cetera. So I completely agree with you that thinking of the spectrum from infections to malignancies in this older gentleman is completely perfect. What to add otherwise to how you've broken it down, very nicely. I really, as I started hearing this chief complain, I totally agree with you that hanging our hat on the chest pain is probably the right way to start, because the fever and the fatigue, as you said, have very broad differential diagnoses. So thinking about what can cause chest pain, it really makes me think of what itises can we get that cause chest pain. from outward in. And I think you're really thinking about cardiopulmonary symptoms as a really wonderful approach, whether there is an actual sort of itis, and I'm using that suffix meaning in English, sort of the inflammatory state of an organ. So are we going to find pleuritis, pneumonitis, or pneumonia, myocarditis, pericarditis, any number of things that really could be causing discomfort in the chest, along with the fatigue and fever itself. I think the time course is going to be really critical, because this has been going on for months versus a couple days. A couple days will really make us probably hone in on the infectious differential, whereas a more prolonged course, I think we really will have to expand with the IMAID spectrum that you already brought up, Sukriti. I suspect there's going to be a lot more, so let me turn it over to Boris and we'll get some more info.
Just to add something, he didn't walk into my office. He was in wheelchair.
Ah, thank you.
So his symptoms started 3 days before the current presentation, when he developed fever up to 38 degrees Celsius with shaking, chills, and malaise. His wife gave him paracetamol and his fever resolved. During the next 2 days, he was feeling well, but on the day of presentation, he again developed fever up to 38.5 degrees Celsius with shaking, chills, but this time he also has epigastric pain, dyspnea, mild chest pain, and extreme fatigue. He was seen by his GP, who ordered the chest X-ray. The radiologist described enlarged heart shadow with findings consistent with pneumopericardium, pleural adhesions bilaterally, and slight lung consolidation on the left. I consulted our radiologist, who also described fluid in the pericardial sac. After this, the patient was sent to my institution. Do you want more info, or you can proceed with this?
Boris, would you maybe just give us up to like the social history and allergies here?
Okay. So beside his hypertension and benign prostate hypertrophy, he was relatively healthy man, and he didn't have any allergies. His social history is unremarkable because he spent much time in his home. He was ambulating, so he was really in good condition until this disease. He didn't have any surgeries. And one important thing, his wife said that patient lost around 50 kilograms in last 6 months because of the diet he was using, smaller food servings. That's all.
Okay, Appy, are you ready to discuss this? So much rich history here.
Yeah, I can do that. So it sounds like it's infection in etiology given the acute fever, and it involved the pericardium and probably have some, like pleural effusion as well, which could be the reaction from the infections like exudative pleural effusion. And given that like he lost a significant weights over the past, I guess, 6 months or something.
Sorry, it's not 50, 15 kilograms.
Okay, but I still feel like it's still significant. Although like it sounds to me that he's intentionally lose weight according to his diet adaptation or something. But anyway, I'm still thinking that it could be, the infection like TB that can cause this, and sometimes it can involve the pericardium and, pneumonia as well. Other than that, it could be malignancy like lymphoma. But again, like lymphoma, it has to be very aggressive to cause a very short, duration, like within 3 days. So that is my differential diagnosis. Other than that, I mean, like I still would like to say that infection is still on the top of my list. It could be bacterial infection as well, but I cannot think of any bug that can cause all kind of these symptoms, including weight loss.
Okay, awesome. Thank you. Thank you so much. I liked how you highlighted the background of the weight loss and said, you know, is this a more chronic thing that is either predisposing to something, you know, acute, or is maybe like there's been something chronic going on and for some reason now kind of is presenting more as an inflammatory process, but also highlighted like the first thing we need to do here is to consider infection, because, you know, in most instances, that's the thing that is going to be deadly the most quickly. And so, you know, here I think it is hard because the older someone is, the harder I feel like a lot of times the more medical things are going on and the harder it is to like parse out if something happening is, you know, related or not. So the 15 kilogram weight loss is definitely ringing alarm bells. Sometimes even if people say like, oh, I lost weight and I was trying to do so, if it's like a lot of weight and more so than I would expect, kind of considering the dietary changes, that doesn't, just because the person says that they meant to lose weight doesn't mean that it's kind of more than would be expected. So I'm definitely wondering if there's some sort of chronic process in the background, whether it be a chronic infection, a malignancy, something like that. Although like with elderly people, you also have to think about practical things like, you know, if they're able to chew because of pain, if, you know, if they have dentures, do the dentures fit? Is that causing issues, access to food, you know, especially if there's like mobility issues, are they getting enough food and everything? So, you know, not all weight loss is malignancy, but I'm definitely kind of like thinking about that, or a chronic infection here. And then with the acute symptoms, they do sound like they're very acute over the last 3 days. Whenever I hear shaking chills, that definitely rings an alarm bell for bacteremia. A JAMA article, I think, showed a likelihood ratio of about 4.7 for shaking chills. So if, which is what I call Rigers. So definitely clarifying to make sure the JAMA article, it was like shaking, whole body shaking, like despite a blanket, has a likelihood ratio of 4.7 for bacteremia. And so definitely, you know, because bacteremia is so life-threatening, I'm thinking about it, although it'd be kind of surprising to have it 3 days ago and just suddenly resolve and be fine and then happen again. But definitely want to get blood cultures really quickly, think about, you know, what are the life-threatening things that I need to treat really quickly here. And then kind of as far as the other things go, these are some really scary findings on imaging. We've got bilateral pleural fusions and pneumopericardium, which, you know, to me, if I saw these findings, I would send the patient immediately to the hospital for a quick evaluation. So, you know, when I think about effusions in the lungs, I'm thinking about what can cause them. Is this a transudative or exudative effusion, which we can use Light's criteria to figure out? So is this just a sign of like volume overload, something like that? Or is there some sort of inflammatory process going on, which kind of goes with our hypothesis? Is it malignancy? Is it infection? Is it autoimmune, which at age 91 would be very rare to have an autoimmune syndrome. So it's kind of lower in my differential, although, you know, still don't want to forget it. So definitely, you know, sampling, depending on how big the effusions, is going to be really important. And then the pericardial effusion, you know, I'm kind of wondering if the same process affecting the lining of the lungs is affecting the lining of the heart. Like, do we have an itis that's causing both a pleuritis and a pericarditis here? And so, you know, I'm thinking about, do those connect? And then I'm also thinking about, is there any signs of tamponade? Like, do we need to emergently evacuate this space? So really looking for Beck's triad, looking for the pulsus exaggeratus, things like that, to say like, how quickly do we need to act as well? And then thinking about, what could cause this fluid around the lining. So when I think about pericardial effusions, I'm thinking about malignancy. Is this a malignant? Certainly with the age, even though there's not smoking and other risk factors, there could be like a lung process that's leading to both pleural and pericardial effusions, or it could be a cancer from somewhere else as well. So thinking about asking about, cancer screening, everything like that. Then I'm thinking about infections. Viral infections are a lot of times can cause like pericarditis. And so you could kind of ask if with a chest pain, if it's better with leaning forward or things like that. You'd certainly want to get a COVID swab. Think about kind of, although COVID doesn't usually cause pleural effusions, but think about like all the viral causes, everything like that. And then occasionally you can get like something with strep pneumo where you can get endocarditis and even get like pleural effusions as well. So thinking about bacterial causes, and then also tuberculosis. So asking about those risk factors has to be on the differential. So I've talked a lot. I'm really worried about this patient. I think we need to act really quickly. I haven't even mentioned like some of the other things that could be going on, but I definitely think that we need to like act really quickly and get him evaluated in the hospital.
We're ready for more, Boris.
Boris, did you want to share an X-ray you have or a picture during this aliquot? You're muted.
Yes, maybe someone wanna see.
Yeah, okay.
Please.
I'll stop share, and I think you should be able to share your screen.
It says host disabled participant screen sharing.
Try again.
Mhm. So this is the picture.
Oh boy. Yikes.
So Anne said that there is a pleural effusion. I didn't said that. I said that our radiologist saw effusion in the pericardial sac.
Oh, I'm so sorry about that. I misunderstood that.
Also a little left pulmonary consolidation.
Wow. Pretty scary X-ray, I have to say. And yeah, just alarm bells going off, seeing, right, there's air in the space between the heart and the pericardium, in addition to the fluid, right? Pericardial effusion alone in this older man with inflammatory syndrome is very concerning, but now there's air. I just want to make a point on this X-ray. A common reason to get air in the pericardial space is because of pneumomediastinum extending into the pericardial space as well. On this X-ray, though, the way we can help differentiate if the air, at least on this type of imaging, is only confined to the pericardial space and not the pneumomediastinum, is we see kind of these pockets of air. They don't actually extend up along the trachea at all. Very classically, when someone has pneumomediastinum, you'll see not only air outlining the shape of the cardiac silhouette, but it will also track up along the trachea. And here on this X-ray, it really looks like it's confined to the space. So just as Anne-Marie was saying, really concerning for specific types of organisms that could be forming gas in there. We didn't hear of any history of trauma that would introduce air from outside the body in there. And then pneumomediastinum, I think we still need to think about if there is kind of air tracking in from that space. And ultimately, if there's air anywhere in the mediastinum or pericardium, making sure we're not missing fistulization from the gastric tract, namely the esophagus or stomach, and then the airways as well. Oof, I think we'll definitely need more than an X-ray on this gentleman going forward, and definitely get to figure out what that fluid is in there. Thank you for sharing that, Boris. You want to give us more physical exam data, or however much else you want for the next section?
Okay, I will give the physical exam. So on the exam, the patient is alert but somnolent with slow thinking, rarely responding to the answers, hypotensive. The blood pressure was 60/40. He had low-grade fever, 37.8 degrees Celsius, slightly tachypneic. His respiratory rate was 24 per minute. Tachycardic, he had a heart rate of 143. Hypoxic, he was oxygen saturation on room air was 66% and 92% on 4 liters of oxygen per minute through nasal cannula. He had cyanotic lips, distended neck veins. Auscultation of the heart revealed the normal heart sound with tachycardia, and auscultation of the lung was unremarkable. The percussion of the chest revealed interesting finding: tympani in parasternal and paravertebral areas bilaterally in the middle of the chest. His abdomen was soft but mildly painful on palpation under the rib cage on the right and in the epigastric region. The rest of the exam was unremarkable, considering that the patient is examined in the wheelchair. That is all.
What do you think, Sukriti? Some additional and still even more scary information coming at us.
I think the vitals are really concerning, and just echoing what everybody said in the last aliquot, that this patient is really sick. And before we sort of think about working him up diagnostically, I'd want to make sure the patient is stable. But if I had to dissect this aliquot, I think, as Boris said, the interesting thing is the tympani and the parasternal, and I think I missed the other area where it was tympanic, Boris. Was it the paravertebral, did you say?
Yes, paravertebral and parasternal, bilateral.
So classically, when I think about tympani, I think of air, air in, so it's normally heard in the abdomen when you're doing percussion of the intestines, and the chest is not somewhere that you'd normally hear it. So this basically signals pathology, and I think layering it onto the chest X-ray, I'm not sure how I would make diagnostic process in terms of etiology with these findings. For me, this sort of confirms what we heard in the last aliquot, but maybe if I were to frame the problem representation, I don't know if that would help. So right now we know that this is an elderly patient with fever and weight loss. So he has an inflammatory syndrome with chest pain, dyspnea, and unstable vitals, and he also has these effusions, which we don't know the nature of, whether they're transudative or exudative. I don't think my differential shifts a lot from just thinking about infection, autoimmune, and malignancy. I think an important thing to note would be his immune status. And also just to see what is the nature of the fluid, like a pericardial tap, if it's exudative and transudative, then I think, but it doesn't seem like he has volume overload, because he doesn't have any edema in the extremities, but he does have those distended neck veins. I'm not sure what to do with this.
Boy, I think, Sukriti, first of all, thank you for helping us with an updated problem representation, because this case has evolved so much that really sort of framing him right now when we see him quite ill in front of us, I think is very important going forward. I also have the same reaction as you of immediately thinking about therapeutics for him, right? This man is clearly sick, that while we're thinking on the diagnosis, the true thing in real life is he would immediately be getting treated. And I saw some suggestions from Travis flash through the chat that this man really needs to be resuscitated. And just a quick point on reconciling that hypotension with distended neck veins, but no other signs of volume overload, gets back to one of the teaching points Anne-Marie made earlier, which is that we are worried about a potential picture for cardiac tamponade here. Not just because of fluid, but I actually wonder the way we think of tension pneumothorax as a cause of distending the intrathoracic pressure and preventing inflow of venous blood from the veins. This man also has tension pneumopericardium potentially also. So the fluid and the air are really impairing the heart's ability to fill normally, as well as the ability to perfuse and cause a normal mean arterial pressure. So what do? Despite the distended neck veins, we definitely need to get fluid in this guy. Because we've mentioned pretty severe life-threatening bacterial infections as a cause, we really need to get antibiotics in this gentleman, particularly really great anaerobic and probably clostridial coverage, because we're really starting to think about gas-forming organisms. And we really have to release both the fluid and the air tension in the pericardial space. So get prepared to do a fairly, I wouldn't even say urgent, emergent pericardiocentesis, and involve colleagues who can help us with that. Boy, that physical exam finding of the parasternal and rib cage air, it's really stumping me too, but it's really helping us localize that something in the middle of the chest is air filled. And that really comes back to, again, we know the pericardium has air around it, but that medial steinal space as well. Because it's a lot more lateral, it makes me think that X-ray didn't miss a pneumothorax either, but I think it's really helping us localize air where it shouldn't be in the middle of the space, in the middle of the chest, I mean. Boris, I'm curious, was there any subcutaneous crepitus anywhere on the chest or the neck or the arms?
No.
Okay, so it doesn't seem like it's tracking out into the skin planes, but there's definitely air right in the chest cavity where it shouldn't be, but not in the lung space, it seems, based on the exam or imaging. This guy's sick. There's a lot going on. Let's keep pushing forward.
So we gave him fluids, and he's after 1 liter of normal saline, his BP rise to 80/40, not so much. We continued fluid, and we performed laboratory analysis. These are pathological values. So his white blood count was 17.8. with 16.63 neutrophils. His platelets were 96. His CRP, C-reactive protein, was 231. His urea was 13.8. Normal is up to 9. His creatinine was 151, normal 100. His estimated glomerular filtration rate was 39. His albumin was 24. His AST was 41. His alkaline phosphatase was 188. His gamma GT was 144. His LDH was 280, and his creatinine kinase was 297.
Hey, Boris, is the urea, is that uric acid or like BUN?
BUN.
Okay.
His AKG showed non-specific changes. The ultrasound of the heart was performed. but radiologists could not see anything because of, as he wrote, bad ultrasound window. So he suggested that we do the CT scan of the chest. I will stop here because the chest X-ray will discover some interesting findings.
Wow, what a case. I think my heart rate is up. Appy, what are you thinking?
Yeah, so that is very interesting. So I think that given the labs, sounds to me it could be like septic shock versus cardiogenic shock, given the pericarditis, I mean like the pneumopericarditis thing, or like cardiac tamponade. So definitely I would consult cardiothoracic surgery for sure. Other than that, I'm not sure. Creatinine 151 means how much, like in milligram per deciliter? I'm not sure. I can't remember how to convert that. But it sounds like you said it's elevated. So the patient also has AKI, which could be, you know, from septic ATN or pre-renal as well. Other than that, LDH is not that markedly elevated. So I think it's less likely to be lymphoma, I guess. Probably, if I understand it correctly. I can't remember exactly, but elevated LDH could mean, could indicate lymphoma as well. Other than that, I'm still wondering why he has like mediastinitis. I would frame it that way. I'm thinking about the pathology from esophagus, whether there is like a fistula tract that drain the air into the mediastinum. Like someone mentioned earlier, some of the infectious etiology that can cause a lot of gas is the Clostridium, the Clostridial infection, or an aerobic bacteria, which I'm still not sure where did he get it from, unless it's from the GI tract. So I think we should do CT chest to see whether that there's to see whether there's a tract from esophagus that it could be aspirated as well, given the consolidation in the lungs. That is how I would frame it.
Yeah, those are some awesome thoughts, and I like how you kind of went through the labs and talked about all the abnormal values, but also talked about like, hey, like we need to get experts involved and surgeons involved, because this sounds really bad and there's a lot going on, and we also need to get more imaging to figure out what's going on. So I completely agree with that. Kind of my thoughts on the labs. I'm not surprised about the leukocytosis. I think we all have concern for infection, or even if it's a stress response and the cortisol is increased because the body is under tremendous stress. That doesn't surprise me. I would be curious about the hemoglobin because the platelets are decreased. So I'm kind of wondering what could be going on. Things like Clostridium can cause hemolysis. And so if the hemoglobin is really down, I'd be wondering about that. Another thing that could potentially be going on right here is DIC. So I'd be interested in the coagulation factors and, potentially looking at a smear. This could all just be due to stress. One of the most common causes of thrombocytopenia is sepsis. Just platelets have the quickest turnover. And so the body, a lot of times with sepsis, when it's under extreme stress, you'll see thrombocytopenia that will later resolve, but definitely want to be kind of looking for signs of DIC or another etiology that could be at play here. And then as far as the other labs, I'm not surprised about the AKI given the poor perfusion. I agree it could be just kind of temporary, or it could be more an ATN here. Looking at the urinalysis might give us some more clues. And then, otherwise, it looks like the AST might be a little up, which, if there's hemolysis, could just be infection. I'm not surprised about the low albumin. the CRP, he's inflamed. I think, doesn't give us a lot of information because we know that. As far as the LDH, I agree with you. This could be like a sign of like lymphoma or something like that. The other things I think about with LDH are just hemolysis. So could there be trace cell turnover? It could just be a sign of tissue damage and poor perfusion because LDH is expressed intracellularly in a lot of cells throughout the body. So, with everything going on in a gas forming organism, maybe that could be at play, and it doesn't seem to be very elevated, so it's kind of a non-specific marker of inflammation, and so not too surprising. And then the CK being elevated just makes me wonder, since we're talking about gas forming organisms, could there be some sort of gas forming organism causing some muscle damage? It's not super elevated, but I would definitely want to be like doing a good exam, looking to make sure I didn't see any signs of it. So, I agree with the broad spectrum antibiotics, stat CT here. I'd probably add on Clenda in addition to anaerobic coverage just for toxin production while we're waiting. This is a case where I would just give like the broadest antibiotics possible with Clenda for toxin production and try to figure out what's going on later. And then I know we've mentioned Clostridium a few times. I'm kind of wondering if there could be some sort of colon cancer or other cancer, but I would definitely think that strep, this could be malignancy, or kind of other things could potentially, tuberculosis could do this too. And so I'm excited to learn more.
Boris, because of the time, do you want to, sounds like you want to show us an image, and then do you want to take us kind of up to right at the end, towards the end of the case, and we can put our final diagnosis in with the remaining info you give us?
Unfortunately, I don't have images of
Okay,
CT,
no problem.
but I will read you the findings. This case shocked us all because we are blind from beginning to think above radiologist findings. So this is the findings. There are no signs of aortic dissection or rupture. Pleura, pericardium, peritoneum, and retroperitoneum are without signs of bleeding or hematoma. There are bizarrely big hiatus hernia which contains stomach, omentum, mesenterium, duodenum, loops of small bowel, and head of pancreas with a diameter of 90 centimeters times 15 centimeters. There is an acute inflammation of the gallbladder with distension of its lumen up to 57 millimeters. Thickness of the wall is 6 millimeters with 8 millimeter stone in the ductus cysticus. The rest of findings are unremarkable. The patient is admitted to the general surgery for further management.
Very interesting. Sukriti, can you make anything out of that very unusual CT finding?
Like a diaphragmatic hernia is just something I associate with infants and neonates in like a pediatric pathology. So it's really unusual in this gentleman. Also, there wasn't any, I haven't thought of any etiologies that could lead to a presentation like this. I think the only thing that comes to mind is like a trauma, like an initial trauma that led to like a cascade of things happening, but then we don't have any history of that. And then it also, from what I get in this is like we got a diaphragmatic hernia, and that could have led to the inflammation that like a leaking of a fluid from the intestines may have led to this presentation of the bilateral the pericardial effusion and the pneumopericardium. But I think we'd have to find out why he had this in the first place.
Yeah, we have to tie this in with what's going on in what seems to be the pericardial space on imaging. And yeah, it sounds like all of these abdominal organs, because a diaphragmatic hernia is relatively common. Usually, right, it's just a portion of the stomach that comes up through a defect in the diaphragm. In this case, the stomach, small bowel, and part of the pancreas came on up through. And to clarify, was the segment of the gallbladder herniated also, Boris?
No.
Okay. So quite a number of organs have herniated through. Now that may account for some of the findings, particularly of the intestines, of what we see as air in the chest, right? And some of that tympany around the spine and around the sternum. Well, it's because there's actually beautifully, as you said, Sukriti, we often think of tympany on the bowel exam. Well, the bowel ended up in the chest, and that's why we're finding tympany in unusual space. What's striking here, other than the hernia, is basically radiographic findings that suggest cholecystitis, right? The gallbladder is inflamed with a thickened wall and a stone just in the right spot, obstructing the outlet of the gallbladder. So I'm trying to piece this all together here, but it seems like there are radiographic signs of cholecystitis. And if we blame some of the epigastric discomfort and the inflammation on that, also could have true clinical cholecystitis. But then how this has affected sort of the pericardial space, again, I'm wondering about sort of fistulization because of the herniation. I can't quite sort of connect what's happening anatomically together to explain it all. Let me just turn it over to AP and Anne-Marie for a few more thoughts, see if we can piece this together before we hear the conclusion from Boris.
AP, what are your thoughts?
Yeah, so I think it's because of the, gallstone that caused the acute cholecystitis, and then it's from like gangrenous cholecystitis, and then probably the wall of the gallbladder rupture, so that the bacterial like spreading into the mediastinum because of the because of the herniation as the underlying diseases. So that's why it caused a lot of inflammation in the mediastinum area, and then causing the septic shock and cardiogenic shock as well because of the pericardial effusion.
Yeah, I mean, that sounds like a great theory to me. I wonder with the massive herniation if there was some strangulation that could have also predisposed to inflammation and seeding of bacteria. But I think that we've got to relieve this obstructed gallbladder stone, and wow, what a case.
Let's hear how things went, Boris.
I'm laughing because someone said mortality super high, but good for this patient. He recovered actually from everything, even in his age. So he was transferred to surgery, as I said. So I didn't have insight in his condition during hospitalization. But what I found that he recovered. So. Some points about this case. One point is I learned from this case is that when you have something on chest X-ray, which is strange, do the lateral imaging. The lateral imaging probably will solve this dilemma in this case. It reminds I didn't made the same mistake too. So me and my colleague, she consulted me because of a woman who had some tumorous mass of the lung, but the tumorous mass was very distinctive from the lung parenchyma. So I told her, do the lateral imaging, and when he did, the patient had a tumor of the spine actually, which was seen on the lateral better than on the frontal plane. So to return to the case, that is the one point. Another point is that actually nobody from the chat and from you didn't notice or didn't find it important that the patient has elevated enzymes of the gallbladder and the biliary tract, which is probably could point to the diagnosis in this case. And actually, what is striking here is that the question which is in my mind, if this patient has actually tamponade-like situation because of all pressure from the organs, or had septic shock, which gave hypotension and everything else. So it is hard to distinguish between these two things in this case. So it is one thing to think of.
I'm just wondering what kind of bacteria is like causing this. Like, did the blood culture turn out positive?
Unfortunately, I don't have that information, but if we look, probably some of the gram negatives, which are most common of a cause of cholecystitis, like Escherichia, Enterobacter, Klebsiella, etc.
And so just to clarify, Boris, there was no pathology of the pericardium at all. What we were seeing was the X-ray findings of the intestines essentially in the chest, giving that mistaken report. And he had terrible cholecystitis and perhaps the physiology you mentioned because of the pressure of the organs.
Yes.
Wow. How interesting. Lateral chest X-ray every time. Such a good point. That's absolutely something that's tripped me up many times. Kirtan, can we turn it over to you for some teaching points?
Sure. Yeah, so what an amazing case. Thanks to Boris for presenting it. Thanks to Steph and Anne for discussing it amazingly along with Sukriti and Epi. So when we start with chest pain and fatigue.
Hey, Kirtan, I'm so sorry to interrupt you. This is Robbie. I'm listening in peripherally, and I just wanted to throw myself into the mix.
Yeah, go ahead.
Specific liver enzyme elevation.
Robbie, it's breaking up. Robbie, you still there? Well, maybe Kirtan, maybe finish, and if Robbie gets a better connection, he can chime back in.
Or I can wait, whatever you suggest, Travis.
Yeah, that works. And if
I just wanted to normalize that. I think a lot of us did that, and I think that's okay, because ATN of the liver is real and shows up like this way. But Boris is here with another great lesson that sometimes the ATN of the liver is actually much more specific than just ATN. But anyway, sorry for interrupting. I just wanted to normalize that, and thank you all for a really, really amazing conversation. And I'll pass the mic back to my dear friend Kirtan.
Oh, well, thanks for another amazing analogy, Rabi, my friend, that ATN and how we can correlate it with elevated ALP. So thank you for that. So yeah, back to the case. When we begin with fatigue, chest pain, and fever, the Steph and Sukriti discussed that apart from the normal things that we look in the general population, in the geriatrics, we have to focus our mind to something else. So we have to worry about the amazing and fatal causes that we should fix first. So things like pulmonary embolism, things like myocarditis, things like pleuritis, some infection, because even when you get old, even if you don't have other immunosuppressive conditions, you can be immunosuppressed because of the age itself. So that we discuss in the first aliquot, that what are the particular infections that you can get at this age and how they can explain the diffuse generalized fatigue along with the fever. Then as the imaging findings and other information came, we gathered the more evidence. And then we had evidence of further weight loss. We had pneumopericardium and probably even pneumomediastinum based on the physical examination findings. So Steph even mentioned that was there evidence of subcutaneous crepitus? So that is known as the Hammond's sign. So if that is there, then that is very critical. We need to fix it immediately. And then when we have got pleural effusion and pericardial effusion, we always have to wonder whether they are transudative or exudative. So that's our first branch point. And when we have figured whether it is exudative or transudative, we can make further progress, whether it is simply inflammatory cause or whether it is something like heart failure or cirrhosis causing the buildup of fluids. And then Anne Mary mentioned that what are the critical things that we have to be aware of. So things like bacteremia, sepsis, endocarditis, which can suddenly cause decompensation in the patients. So we should be aware of those things. And then finally, when the labs came, the vital signs were grossly abnormal. So then the Steph mentioned that we have to take a step back and realize that rather than getting to the diagnosis, we should first fix the vitals. We should immediately go for pericardiocentesis, if possible, to relieve the pressure that is building on the heart, just like how we go in pneumothorax, how we decompress the chest wall. So similarly, we should manage the pneumopericardium, and then after giving the fluid, we should see whether the hypotension is improving or not. Unfortunately, in our case, it didn't improve. Then finally, we came to the labs. So in the labs, we had evidence of low hemoglobin. We had the evidence of elevated platelet count. We had the evidence of elevated WBC count. So the Anne Mary mentioned that what if this is indeed a sepsis or DIC-like condition, and then we even have a slight elevation of LDH. So that can point to maybe hemolysis, maybe ischemia, maybe even some extent rhabdomyolysis. So we have to consider what if this is DIC or sepsis, and we need to fix that immediately. And all along the discussions, we were worrying about the bacteria which can cause all these things. So in the chat, the Travis and all of us discussed that how Clostridium, Fusobacterium, all these gas-producing bacteria can cause these symptoms. And at the last, we were sure that if nothing makes sense, it has to be some anatomic problem. So even in the previous aliquots, we mentioned that what if there is some sort of fistula between the abdomen and the pericardium, which can explain all these things. And eventually, it turned out to be very similar to that. So we had this massive hernia, which was compressing the thorax and which was basically leading to loss of the barrier which is present between the thoracic cavity and abdominal cavity. And that's why we can't stop the inflammation. Once we have loss of that barrier, you will inflame the mediastinum, you will inflame the pericardium, you will inflame the pleura, you will inflame the heart itself. So that was very terrible. And then the Boris taught us very astutely that always look for the lateral X-ray, because in lateral X-ray, you can see things which you can't see in the AP or posterior anterior X-ray. So it is very necessary to get the lateral X-ray, and simple things like lateral X-ray can give you many new findings. So it was very amazing case. Thank you everyone for joining us, and looking forward to see you next time. And maybe we can see if Rabi is there, then he can teach us more if he wants to.
That was awesome, Kirtan. And Robbie just made a good point in the chat about doing a pericardiocentesis. Imagine this guy coming in distressed. He's hypotensive. He's got elevated JVD. You have this X-ray showing that, and you're like, this guy's in tamponade. And maybe something happens, and you go to try to do that, and guess what? It's not there. You're going into small bowel. I mean, just what a amazing case and differential. So thank you, Boris, and thanks everybody.
Thanks everyone. Have a great day.